Hi, everybody. My name is Dr. Cindy Mossbricker, and I am the founder and owner of Pacific Endometriosis and Pelvic Surgery in Gig Harbor, Washington. I've been doing endometriosis surgery for almost 20 years and was trained by Dr. David Redwine. Today, we are going to talk about adolescent endometriosis. And give me a second here, and I'm going to share my screen, and hopefully it will all work. So this is the first part of what will likely be a two-part series. So what are the issues? Well, 10 to 15% of teenagers have endo, which is no different than the incidence in adults. However, the delay in diagnosis is way worse than in adults. Typically, it takes 5 to 10 years, which means these kids are not kids anymore, and 4 to 7 doctors before somebody recognizes it as endo. This is ridiculous. 60 to 90% of teenagers have dysmenorrhea, 40% have severe pain. However, 60 to 75% of teenagers who underwent a laparoscopy were found to have endometriosis. And that number was 75% in a study where these girls failed oral contraceptives and ibuprofen and continued to have pain. So a significant number of these teenagers will really have endo. Even ACOG, as much as I hate ACOG for their lack of concern over surgical education and specifically endometriosis, recommends doing a laparoscopy for teenagers who have persistent pain despite being on OCPs for 3 to 6 months. 60% of all women with endometriosis state that their symptoms started as a teenager. Typical cyclical pain, which is usually called dysmenorrhea, is often accompanied by these other vague symptoms like generalized abdominal pain, GI discomfort, including cramping and bloating and nausea, as well as urinary symptoms, and pain that is not cyclical sometimes can confuse regular gynecologists because they're not expecting that. And so the more complicated the symptoms become, the less certain they are of what to do. In addition, coping strategies are not well developed in many adolescents, so pain perception is heightened. And we're going to talk about that in part 2 of this. So dysmenorrhea is cramping due to uterine pain. It is categorized into primary dysmenorrhea and secondary dysmenorrhea. Primary dysmenorrhea basically means that there's no pathology, it's just uterine cramping. Secondary dysmenorrhea typically means that there is something causing it, such as adenomyosis, endometriosis, fibroids, and the like. Typically, secondary dysmenorrhea doesn't start at the very first menstrual period, but that's the textbook definition and not the reality. The reality of endometriosis is that a lot of times the pain does start with the very first menstrual period. So how does dysmenorrhea work, and why does the pain become why do these women get pain? Omega-6 fatty acids are found in corn oil, sunflower. Omega-6 fatty acids convert typically linoleic acid into arachidonic acid. Linoleic acid is found in seed oils and corn oils. So corn oil, sunflower seed oil, soybean oil, things like that. Basically Wesson oil. The things that McDonald's fry their French fries in. Arachidonic acid is the precursor of prostaglandins. And this cascade is how non-steroidal anti-inflammatories work, by blocking the cyclooxygenase, which is the enzyme that converts arachidonic acid to prostaglandins. So prostaglandins cause vasoconstriction, contraction of the uterus, diarrhea, and uterine ischemia, and then pain. So prostaglandins really are the mediator of pelvic pain in women with adenomyosis and endometriosis. We're going to talk about these things later as well in part 2. So this is a chart of symptoms in adolescents with endometriosis. And as you can see, they're kind of all over the map. So doctors are taught that cyclical pain, especially pain with menses, pain just before the menses, that is crampy and sometimes sharp, is typical of endometriosis. However, when the pain is accompanied by all these other things, then it is confusing to them and they have a hard time making a diagnosis. In my experience, kids are not concise. They don't come into my office and say, I have pain with sex, I have pain with my periods, I have pain with bowel movements, and leave it at that. No, they're like, everything hurts. I don't feel good. Where does it hurt? Well, everywhere between here and there, basically everywhere between their diaphragm and their hip bones. And they're not really good at describing exactly what's going on because they don't understand it. And so all of these things contribute to an inability to make a diagnosis. And in fact, the less precisely someone describes their pain, the more that doctors will think that they are faking it. So this is a study that is from Russia, and it's really kind of an interesting study. It was an observational study of 90 girls surgically diagnosed with endometriosis, less than 17 years old, and then 44 age match controls. And what they did was they compared the historical data, not necessarily the surgical outcomes. And so they asked them all these questions prior to surgery and then compared the endometriosis group with the control group. And many things stood out in the history that were statistically significantly different between the endo group and the control group. And what you look at for statistical significance is this p-value less than 0.001. Oops. And so we'll go through several slides. Family history, pregnancy complications in their mother, and mid-cycle spotting are significantly associated with endometriosis. So is the onset at the first period, which 63% versus 9.9%. And then finally, pain that is persistent despite the use of nonsteroidals like ibuprofen and Aleve, moderate to severe dysmenorrhea, pain that influences somebody's daily activity, GI symptoms, urinary symptoms. All of these things are significantly different. And you can't see underneath my picture, but all of these are less than 0.001%. So this gives us a lot of information. And with this data, we should be able to make an algorithm such that any of the following symptoms that we just talked about should increase someone's suspicion for endometriosis and lower the threshold for laparoscopy. So moderate to severe pain with menses, pain that's not resolved with nonsteroidals, and I would add birth control pills. Pain that starts with the first period or soon thereafter. It's associated with intestinal and bladder symptoms. It's associated with heavy bleeding and mid-cycle spotting. And then you combine that with a family history of dysmenorrhea, heavy bleeding, pregnancy complications. I would also add a family history of known endometriosis or adenomyosis. And these girls are probably 90% likely to have endometriosis when you add all these things up. And so it begs the question, why are we not teaching this to pediatricians, family practice docs, and general gynecologists? I don't know why. To me, it's not rocket science. It's fairly simple. But on the other hand, we really don't want general gynecologists operating on these girls if they don't understand endometriosis and they don't understand what it looks like in teenagers, because it does look different. And the only thing worse than not having a diagnosis is somebody having a laparoscopy, being told they don't have endometriosis because it doesn't look classic, and then they actually have disease. To me, that would be worse. So this is a picture of from that study showing that almost 60% of these girls had very clear lesions. And Dr. Redwine used to call these tapioca spots because they were really the glandular elements of endometriosis, because endometriosis is defined as endometrial glands and stroma outside the endometrial cavity. And so the glands initially don't bleed, and they just kind of create some substances to give it a raised kind of a sense. And then next they bleed bright red blood into them. And so the highest likelihood in these teenagers was for them to have clear lesions and red lesions, and much less likely to have black and white lesions. That's because the black and the white lesions take more time to form. Dr. Redwine published a study back in '87 looking at the evolution of lesion appearance in various ages. And again, what he found was the clear lesions only have the youngest average age, followed by red, followed by white, and then finally the black tends to be in the oldest age groups. And that's because as the endometriosis progresses, the bright red blood becomes black and then essentially causes these little miniature endometriomas in the tissue. The white lesions probably have not bled, but they have caused a fibrotic tissue reaction to get the white appearance of the lesions. So this is a study that that was basically this is a paper that included a chart of different studies looking at endometriosis in teenagers. And what you see is that the early studies prior to the year 2000 or so, very few girls with stage 3 and 4 endometriosis were found. And so that led people to believe that, well, teenagers don't have advanced stage disease. But after 2000, all of these studies down here, you can see there's a lot more stage 3 and 4 disease. And probably that's because the average age, or the upper limit age, they included girls that were 20 and 21 rather than stopping at 19, which most of the earlier studies did. But basically, there was another study that I read that I don't remember exactly where it was, but it said that the likelihood is that if a girl is less than 16, like 13, 14, 15, probably 95% of those girls will have stage 1 and 2 disease, versus only 5% with more advanced stage disease. Whereas after 16, then the distribution is no different than what we see in adults. This is another study that really seems kind of cruel, almost in a way. They took 28 patients who were, I believe, less than 18, who were diagnosed with endometriosis during the time period of 1993 to 95. They had only a diagnostic laparoscopy with some peritoneal biopsies for confirmation of their visual diagnosis. And then they were given 6 months of birth control pills. And then in 2002, they contacted them to see if they had been pregnant and if their pregnancies were successful. And this is what they found, that 75% of the girls with stage 1 disease were able to get pregnant. 3 out of the 4. 6 out of 11 of the stage 2 became pregnant. 3 out of the 12 stage 3, so only 25% of the stage 3 disease, and none of the stage 4 patients. Well, there was only one, so it really doesn't count. But they didn't state whether or not these patients had subsequent surgery. They didn't state whether they had infertility treatment. It says there was a line that says further treatment, which was 2 and 3 in each of the stage 2 and 3 groups. So we don't know really if they had additional surgery, but this is kind of pathetic. And it illustrates to me the need for early intervention, early surgical intervention to save these girls' fertility. This is another study done by Ken Snervo and Patrick Young, where they operated on 20 girls who were teenagers less than age 19. And 17 of them had endometriosis and had complete surgical excision of endometriosis. Almost 2/3 of them had stage 2 disease, and they were followed for up to 66 months with an average follow-up of 22 months. And what they found was that every aspect of their pain improved. However, some of them were statistically significant and others were not. So this is just a written out value of that bar graph. Pelvic pain was not statistically significant. Dysmenorrhea was, pain with sex was, pain with bowel movements, constipation, pain with exercise, GI cramping, and bladder pain all decreased significantly. Moreover, in this time frame, 1/3 of them took birth control, 1 was on Lupron. There was no difference in their improvement. There was also no difference in the number of patients who had to have subsequent surgery. About half of them had subsequent surgery. Most had filmy adhesions. None of them had endometriosis. So at an average of almost 2 years later, there was a 0 rate of recurrence of endometriosis, which for teenagers is pretty good. So this tells us that it really doesn't matter if these girls are on birth control after surgery or not. My personal feeling is that if they want to be on birth control to either stop their periods or to stop them from getting pregnant and they feel fine on it, go right ahead. If they don't like how they feel on birth control, then no need to take it. So this is the end of part 1 of our series on adolescent endometriosis. Thank you for joining us and stay tuned for part 2. Take care.